The ultimate failure of central planning is that everyone's looking for some sort of metric by which you can measure the demand for physicians, and that just doesn't exist, right? We don't measure access to care in any meaningful way, and I don't know that we necessarily can.
Accepting women at a slightly more than 50% rate into medical school, yet when you look at the numbers, women are staying full-time. It's a stark difference, right? 22.6% of women physicians are not working full-time compared to 3.6% of men.
The private industry incentivized doctors to stay longer, made the work more enjoyable, stopped burning out everyone, stopped lowballing them through CMS, and really made being a doctor great again.
Our healthcare system was dominated by doctors who had leadership in our healthcare system, and that's all they thought about. That's what we're trained to think about in medical school, is how do we treat patients? How do we take care of them? How do we get them better?
Welcome back to the Doctor's Lounge. Just in case you didn't know, our friends, dear audience, we are now successfully on Apple Podcasts after I screwed the pooch for 4 months or something. I don't know. But anyways, thank you. Apparently we have 400 plus downloads as of today, and we're ranked 97th. I don't know if that's good or bad, but 97 sounds pretty good out of 100,000 podcasts.
Well, my dad did download this 60 times, so I don't know.
Yeah,
I was going to say, I think it's mostly
on 60 different
family.
computers. I know I got my mom to do it, my sisters and everybody I knew, and I was paying people on Fiverr, hey, download this podcast. Here's a Fiverr, really?
Yeah. My mother-in-law with a flip phone, I got her to download it. It was great.
All right, today, hey, listen, just to get us started, I want to do a news segment. I don't know how we're going to do it over the next couple of weeks, but we'll see how it goes. So there are a couple things that I saw that I thought you guys might want to comment on. I shared them in the show notes with you, but I want to start with number 4. And I don't know what to do with this wonderful representative who also happens to be on the Doc Caucus. Representative Greg Murphy says we need more foreign doctors and more HB1 visas.
H1B.
Dr. Dan Choi, what do you say?
I think that this is an interesting way of, solving our doctor shortage. When you really think about the U.S. education system right now, and I in my private practice, I get inquiries every single week for high school students, pre-medical students, college students who are really yearning to enter the field of medicine. And I think that applications are year after year, you have more and more interest actually in medicine, even though we're sitting here typically on this podcast and a lot of doctors are talking about how they would probably not recommend medicine to be a field for their children. Actually, what you're seeing is interest in the field of medicine growing every single year. And you know what? That just speaks to our future generation, the hope that they have. And we have a bright future. We have a bright future in medicine here in America with all this interest. We have a lot of talent here in the United States. And why are we not tapping into that? And why are we not opening more medical schools and making the barrier of entry? And that also starts with residency spots here in America. We don't have enough. I know that a field like orthopedic surgery, which is a highly sought after specialty, the match rate is 70% or lower, and that's probably an outdated number. And so you have a ton of interest in U.S. citizens becoming physicians, serving our own population. Why not tap into that before we start resorting to H-1B visas is my initial kind of take on this.
I think that's a solid take. Dr. Koka, Mr. Capitalist, Mr. Free Markets.
There's one of those where the rubber meets the road moments where, you have to understand that there are certain realities that are shaped by policy. And some of those are what's operative in terms of what we're seeing with this demand. There's certainly high demand for H-1B visa, meaning these folks who have international medical grads that come over here. But there's the local populace, has needs and demands as well. I mean, the numbers are pretty interesting, right? There's about 50,000 approximately most years for the last 5 or 6, 7 years has been about 51,000 applicants to medical school every year. There was the Fauci effect in 2020-21, and there was a surge in applicants, about 20% more. There were 62,000 applicants. So normally about 50,000. There's this huge surge because everyone is so motivated by Anthony Fauci, I guess. I don't know, called the Fauci effect. and that has now come back down to around 50,000. The issue, of course, is that when you look at acceptance rate, the overall acceptance rate to med school is around hovering around 40% or so, right? So 60%, whatever, 2 out of 3 or approximately domestic U.S. citizens are being denied entry into medical school, getting to the point of, if we have a need for more doctors, why are we denying 2 out of 3 U.S. citizens from getting into medical school? And then later on, as we get to residency, there's so many residency spots that are open. We then have to fill those with international medical graduates because the U.S. population isn't able to fill that. And so that's a little bit of a choice that we're making there. So we need to certainly increase the lower the barriers to entry, as Dan is saying, to get U.S. U.S. citizens prioritize U.S. citizens. The other part that's unfair and really rankles people who just get a little bit into the topic is that international medical grads. Certainly, I know I can speak from the Indian perspective. India, there's what's called the MBBS degree, which is 5 years after high school. So you get an MBBS degree 5 years out of high school. If you go to a public university, which is relatively competitive to get into, you have to be pretty good academically to do that in India. It's much more competitive than, say, 40% of all applicants getting in. If you do get into a public university, then your fees are very, very small, very nominal, and you graduate with like no debt, right? And then you come over here after your MBBS, then you do a residency here. Remember, that residency is paid for by taxpayers. And then you go and you practice, and you basically are making the same amount as any U.S. medical grad is. So, and you can't contrast that with the road that a medical student here has to take, which is 4 years of med school after college, right? So 4 years of college, 4 years of med school, 3 years of residency, a minimum 3 years residency to some of the general specialties like family med or internal med or pediatrics. If you do a subspecialty like cardiology, you add 3 or 4 more years to that. If you want to do neurosurgery, ortho, same thing. It's 6-7 years after med school, and you graduate with $300,000-$400,000 worth of debt. So this is you can see why why are the barriers so high? Like it's easier to send a kid to a foreign med school and then have them come back and not have to do that, not have to go through these and pass these hurdles. So I think there's an issue there. To steelman the counter to what Greg Murphy was talking about, saying Greg Murphy keeps talking about the fact that there's massive scarcity in rural areas, and the only people that will fill that are foreign medical grads, meaning there aren't enough U.S. medical grads to do that. I think that's fair, certainly in the short term. I'll say that there are probably way too many residency programs. There are many, many, many residency programs that exist on the periphery in outside of the major academic centers that exist primarily as cheap labor for, you name it, hospital system. When they could pay to get PAs or NPs to do that. But hey, if you're gonna get free labor and a lot of free labor, plus they make money on each grad they get, right? It's not that the U.S. Taxpayer is paying them the exact cost of what they're paying, right? They're actually paying them more than that, for the training purposes or whatnot. So there's that piece of it where, and then in terms of like the demand that Greg Murphy's talking about, where I think he's also wrong, is that there's a huge amount of supplier induced demand where you have a ton of, if you go to these small town hospitals or small town communities that I go to, like say the Jersey Shore. I mean, it's insane how many medical clinics there are and how many beautiful places there are down the shore. I mean, GI, rheumatology, cardiology. And then these are not like just like 1 or 2 random cardiologists. This is like big, it's like, big cardiology groups that are there, big nephrology groups that are there. And you ask yourself, how the heck is a population that is this small relative to, say, Philadelphia. How is it supporting all these folks, right? And then it gets into the whole, look, well, you got third-party payment systems, right? And you have a doctor, willing to do a service. You're going to get if you add that third-party payment, you're going to get a lot of services done. So it's complicated because the pure capitalist would argue, hey, whatever, there's demand, just allow that to be filled. But everything gets screwed up. There's so much distortion when you have third-party payment systems that I think a lot of what Greg Murphy's talking about in terms of saying, his counter to us talking about all this is that, hey, we've got all these folks in rural America that need care. I think a lot of that care, if we're going to be honest, a lot of that care that's being delivered may very well be, supplier induced, meaning doctor induced demand.
Dr. DiGiorgio, I'm looking forward to your answer. What do you think about HB1 visas in general? And I think you have a good sense of Dr. Murphy's outlook. Do we need more HB1 visas to support the physician shortage?
We don't know how many physicians we actually need, right? This is like the ultimate failure of central planning is that, everyone's looking for some sort of metric by which you can measure the demand for physicians, and that just doesn't exist, right? We don't measure access to care in any meaningful way, and I don't know that we necessarily can, right? So take, for example, I need to see a cardiologist. Okay, you're too far away, but it's like an 8-month wait here in the Bay Area to see a cardiologist. It's crazy, right? So, but what's the right wait time for a cardiologist? Should I be able to, see one tomorrow if I get the inkling, or should I have to wait a few months? We don't have any meaningful, way to measure demand. That's what price signals are supposed to do. That's how we know where to allocate resources if we have a functioning market, is that price signals are the best way to allocate resources. And if a rural community really needed a neurosurgeon, we would know that with the price signals, and that would attract a neurosurgeon to that community. And yeah, they might have to pay a little more than the Bay Area because nobody wants to live in rural Montana and do neurosurgery, but somebody might, especially if the pay is enough. And then on the other end, and this is the point I keep bringing up that nobody mentions when it talks about this so-called physician shortage, is that on the back end, we're driving physicians into early retirement because we've made the practice of medicine, especially primary care, so terrible, right? If you're going to sit there and get paid Medicaid rates for your, clinic-based E&M visits, and have to fill out a bunch of paperwork and do a bunch of prior authorizations all night, and be sitting there typing and not really seeing your patients and not having meaningful connections, who wants to do that? So people are leaving, the third-party payer workforce. They're going into direct primary care, or they're going to early retirement, or they're going into industry or consulting or something like that. And I always go back to this Elsevier med student survey they did. It showed even the med students don't want to practice medicine, that about 2/3 of them plan on going into consulting or private industry or public health because they don't actually want to do clinical medicine. So clinical medicine itself is becoming less and less attractive. We're training people. We have a workforce out there. We're just not incentivizing them to actually practice medicine.
And we should also talk about the big time gender gap when it comes to this lack of physicians per se, right? We're accepting women at a slightly more than 50% rate into medical school. Yet, when you look at the numbers, at how many women are staying full time. I mean, it's a stark difference, right? 22.6% of women physicians are not working full time compared to 3.6% of men. If you're a woman that's had a child, that number is 30.6% that are not working full time, right? So 30% of women doctors are not working full time. Now, a lot of us have wives that are female physicians, of course, and we certainly don't fault them for choosing to not be part-time. That's not the point. But it's a very, very interesting demographic shift that's happened, right? We've gone from almost 90% men in medicine to 50-50 in terms of med schools, graduating classes certainly. But that shortage has gotten more acute, and there's a lot to that shortage in terms of price signals and central planning and stuff. Certainly, that's a very important number that we need to keep in mind. Of course, Greg Murphy got in a heck of a lot of trouble, right? For online trouble, for suggesting that if we're going to train, if the U.S. taxpayer is going to train you, right, and pay all this money for you, why, is there any responsibility to stay full-time for some period of time or whatnot? I'm curious. We'd love to hear what you guys think of that.
The interesting thing I think about his comments is he kind of is a typical lawmaker, and I'm not saying it to be unkind, but just as a matter of fact, he had another tweet, October 8th of last year that said, we need to reduce the amount of HP-1 visas we're issuing. They're taking all the American jobs. It's kind of the quintessential right wing. I'm a Republican in North Carolina. I want to get elected, so I got to say this stuff. Okay, go ahead.
Except if you represent a rural community that has some regional hospitals that are 80% IMG H-1Bs, then we need an exception.
Right. Then we need an exception. Okay, so my follow-up question for you guys is, in 1997, this is the thing that stinks about getting old, right? Like I'm turning 50 this year, and I'm like, okay, so I remember the balanced budget
bill, Bill Clinton,
right? And so Newt Gingrich, Bill Clinton get together, right? The enemies of enemies, but they get together like good American politicians should, and they say, we got to balance the budget. What we're going to do is we're going to put a moratorium, if you will, on the residency budget, not slots, residency budget. And then what we're going to do is in 2 years' time, we're going to have grown the economy and we're going to remove that moratorium. Now, as we all know now, because it's 2025, that never happened. Now, some spots increased, but those were privately paid for. So with all of that, one of my questions is, what can we reasonably do to grow the amount of American-born physicians? What actions can universities take? What actions can we take as a whole? And I'll start with you, Dr. Choi.
I always focus on probably the systemic, larger, picture, which is, and I talk about this a lot on this podcast, which is just lobbying and advocacy, right? If that's the law that's limiting supply right now, you got to change the law. It's having the law is having its intended effect, or maybe it wasn't intended. It was a budgetary intent, but now it's very clear what the effect of the legislation is. It's extremely clear, and there may be again, Greg Murphy, follow the money, right? If there's a regional hospital system that's in his ear, being the largest employer, right? And a lot of the systemic changes that we need from a legislative standpoint, one of the biggest barriers is these health systems are such large employers of they have every House representative's ear, every senator's ear, because of the jobs that the number of people, the sheer number of people they are employing in the state, which sure, that's a good thing. They're creating jobs, but they have such consolidated market power in their local markets. How many jobs are they sucking away from the private industry, right? Private practice, right? By what they're doing too. So you don't know if that's necessarily a good thing, but you've got to start there. We've got to educate more legislators. The AMA's got to be a leader on this and go back and increase the budget to train more U.S.-based, U.S.-born, U.S. citizens here in the United States. We know what the problem is. Let's fix it legislatively and get rid of the law that's limiting the supply of doctors, U.S.-trained doctors.
Dr. DiGiorgio, I'm really anticipating a good answer here. I feel like you're going to start the conversation. All right, let's go.
The Medicare cap on residency slots did nothing to affect the growth rate in residencies. So that's my controversial take. Since that cap was instituted, there's been a 27% increase in total residency slots. The U.S. population has increased by 21% since then. So residency growth is not our bottleneck. And I think we're in danger of, like Anish alluded to earlier, having too many marginal residency slots. Because, at least from a neurosurgery perspective, I don't think we can really open up that many more slots and offer quality training to have good, competent neurosurgeons practicing. There's just, you need a breadth of cases, you need a depth of cases that you just can't get by opening more slots. health systems realize that they can make money off of residencies, right? The example I love to use is University of New Mexico lost their residency program. They had some ACGME violations and they lost their program. To replace the labor of 8 residents, they had to hire 23 NPs and PAs. So to replace 8 very cheap laborers, they had to hire 23 very expensive laborers. So there's a huge cost trade-off. Now, not every program is neurosurgery, but residents are pretty inexpensive labor, and there's a good return on investment, even if you're not getting reimbursed by Medicare to train residents. So I don't really think that residency is the bottleneck. It's really hard to expand residency. And again, I think coming back to it's keeping people in practice after they finish residency, making sure that they are practicing full time, and making it so being a doctor is enjoyable and fulfilling again, so that people aren't just either working part-time or looking for an early exit or getting out of the workforce. I think there's, some areas.
I love this take. I love this take. Oh my gosh. So what I just heard was, it's really not there is a physician shortage, but we could solve it if the private industry incentivized doctors to stay longer, made the work more enjoyable, stopped burning out everyone, stopped lowballing them through CMS, and really made being a doctor great again.
And let us own healthcare.
Let us own hospitals.
Let us own hospitals. Let us own our own independent clinics. Make it feasible to build something. Make us, physician, professional entrepreneurs a thing again. Then I think, you're going to have less and less burnout. If I owned my own practice and my own hospital, I'd probably, feel a little less burned out every day.
This is good. So Dr. Koka, so you heard what Dr. DiGiorgio just said. What do you think? If you owned your own cardiology hospital, would you enjoy being a doctor more?
I mean, I own my own cardiology practice, and I think I enjoy it a lot more than
I love my job. Yeah. Don't get me wrong. If anyone's listening, I love my job.
No, but I totally agree. I totally agree with Anthony that I think the issue is I don't know that necessarily that I'm not opposed to someone setting up more medical schools and getting more med students in. I think that ratio of accepting more folks is probably not a bad idea, though you'd like to think that physicians, you want a select group of folks. I mean, if the admission rate to medical school is 60%, do I feel that great about getting sick? I mean, I don't feel that good about getting sick and heading heading anywhere right now. But no, my point is, I don't know that necessarily we want to solve this problem by just increasing supply. I think, if you increase supply and you end up, pushing a lot of kids and a lot of folks into places where they burn out, and, say 30% of women, as I've said, are not working full time, then what exactly are we doing? I think you really have to improve conditions, and I think that you have to take away some of that government Midas touch, which has really captured a ton of physicians in very inefficient places, right? Like, think about Dan, or look at I was going to say, Anthony. Think about how much more efficient, productive Anthony could potentially be. Somebody like Anthony, not to put Anthony on the spot, but I think we have, it's crazy when you have incentives set up a certain way, how much labor you can set up to do not that much, right? I mean, in cardiology, you have this super subspecialization where you have a left atrial appendage cardiologist, you have a cardio oncologist, you have a cardiac critical care doctor, then you have a cardiac metabolic endocrinologist, and everyone is starting fellowships for that. And the fellowships, I mean, it's just insanity. And it's like, literally, what does the patient want? I had a patient who I stopped seeing the patient. I was like, my goodness, you're seeing so many doctors at this academic health system. Just stay there. He's seeing 4 cardiologists at this health system because he has some rare cancer that he has to go to this this academic health system to and get CAR T, which is only offered there. And as part of that, their protocol is to have him see a heart failure doctor, general cardiology, EP, and cardio oncologist. He's seeing 5, and somebody to manage his device. So he's seeing 5 cardiologists. He has 5 different appointments. He's like, doctor, I spend more time with cardiologists than I do with my oncologist. and then he was still coming to see me. I was like, sir, you do not need to come see me.
Yes.
So you can see how
Choi?
that's a huge issue. Sorry. I think
No.
I think we may have enough physicians. You just may not know it because of how screwed up the system is.
So I've heard before that we don't have enough. It's not that we don't have enough physicians, is that we don't allocate them appropriately, which I think Dr. DiGiorgio talks about distribution, right? No price signals. Dr. Choi, do you think that if there was no certificate of need laws in New York City, in New York in general, right? We've all fought against those for a long time. And there was no moratorium on physician-owned hospitals. Do you think that being a doctor would be more pleasurable? And do you think that New York doctors specifically, I ran around with them for more than a dozen years, right? Most of my doctor friends are New York guys. And so do you think that they would not quit? And do you think they'd enjoy medicine more? Like, do you think it'd be like, we'd have way better healthcare than we do today?
Look, I just want to ask Anish, are you busier now than you were 8 years ago, 5 years ago? In private practice, do you feel like the demand is increasing or kind of steady, decreasing?
Yeah, no, I think demand is up, but it's hard to separate that out from just the general what happens if you stay in practice for a while and people will get to know you and stuff. Meaning, yeah, demand is clearly up. Is demand up because I'm just so freaking amazing and people have heard or more and more people are hearing about me, or is it actually that Philadelphia's demand for cardiology has gone up?
Look, I have
Philly cheesesteaks. Yeah.
In our practice, look, we've brought on a new surgical associate, and I have to tell you, she's gotten busy like right out the gate, and the demand for private practice, I think, has never been greater because of the inefficiencies of the health system, of the large, massive consolidated health systems, and you just don't have the same impetus and the same driving factors for clinical output that private practice has. And I've talked about this over and over, where a health system is you have all the decisions top down with a non-practicing administrator who isn't sitting there thinking about how to maximize clinical output. Anish and I, and also Anthony, I'm sure you wish you could do this. Sometimes you're probably held, but my outpatient space is designed to maximize clinical output. I want to see and treat and get in as many patients as I can, so that, guess what, when the new patient calls, I have enough spots so that they could be seen next week. Or within a week. That's the best private practice business model, that I have to maintain that standard of access to my patients when they call. And that means I have to optimize systems to make sure that patients can get in quickly, and then also maintain high quality of care and throughput, and then patient experience. All these things I'm thinking about, right? That our healthcare system was dominated by doctors who had leadership in our healthcare system, and that's all they thought about. That's what we're trained to think about in medical school, is like, how do we treat patients? How do we take care of them? How do we get them better? And when we are running the systems that are trying to accomplish that, then we're thinking about every single thing. I'm thinking about intake, like people sitting in my office, like, how do I speed that up so they're sitting in my waiting room not 30 minutes but 10 minutes? How do I get their demographics in a more efficient manner so that their experience is a little bit more frictionless, so that we can get down to the meat of why did that patient come and make an appointment with me in the first place? Not to access a spine nutritionist or get some pamphlets on some things. They want to find out why they have back pain. What imaging do I have to get? What procedure, surgery, medication do I need? And get them out the door and help them feel cared for, and also have a positive experience while they're there. And that's really, when physicians run the system, that's what we're thinking about, I think. And we need more of that driving our healthcare system. We don't have that right now, because doctors have been locked out of the system. We've been locked out of access to capital. We've been locked out of being able to control the delivery system, right? And that was by design, right? You take away the control from the physicians, then the physicians have to do as the administrators and the legislators say that they want to. But in the long run, as the AC has proven over the last 15 years, it's a failed experiment. You've decreased clinical output. You've decreased efficiencies. Look, I'm looking for a pediatric urologist right now to circumcise my newborn son. And you know what? I can't find one for 5 weeks in the Long Island area. That's horrible for my newborn. And I that's the first available from about 4 weeks from delivery. And that is just unacceptable, in my opinion, in a metro market. We're not in, rural Missouri. We're in Long Island, and I can't find a pediatric urologist. Guess what? There's no pediatric urologists in private practice that I know of. They're all kind of locked up in the systems. There's calling every day for cancellations, and I'm experiencing it. The shortage is real. The clinical inefficiencies is real, and it's affecting me as a patient. And this is a setup that's set up for systems. I think all the regulatory captures like CON, all these things. Look, not all doctors are great at business, and not all doctors are going to run practices. But there's enough doctors who are business minded, and there were enough doctors 50 years ago, 40 years ago, 30 years ago that figured out how to run practices. The legal field is the same right now. There's no legal consolidation of lawyers right now. Lawyers work in these small businesses, these law firms, and that profession is robust and doing phenomenal. And we all have access to great legal care if we want, right? If I want to sue someone in America, or I want to, I get hurt on the job or whatever, I have the world of attorneys that I can go and they'll take my case in 5 minutes. Actually, like the legal profession has the highest amount pay per click on Google advertising. If you try to do personal injury, it's like $200 a click for those guys. You don't have the same robust marketplace in medicine when we could have it all. Like in this country, we could have a market-based, you could unleash all these doctors who want to help their patients, and you could have this amazing healthcare system, but you've locked up the doctors and prevented them from running the system. And this is why we have the mess we have.
Well, we should pass a law saying lawyers can't own law firms. That'll fix that $200.
That will solve it.
Google ad space, right?
All right. So I want to thank Representative Dr. Greg Murphy for this wonderful news bit. I feel like we should send him a donation, maybe a little PAC donation for giving us the bid on HB1 visas. All right. So one of my other thoughts was, you guys know, I love Secretary Kennedy. And, it's like having a really good friend that says really dumb stuff. And you just go, what did you just say? So I'm watching X, and up comes a video on Sunday, and he's standing there and he's like, well, I want a health system that doesn't incentivize doctors to choose high priced treatments. And I think that they don't want to heal people. I think they want to, generate more revenue. This is the head of HHS. The guy that I thought, would probably make a pretty decent president. I have a shirt that says Surfers for Kennedy, So I'm telling you, I was blown away that guy would stand up and say that. And I want your reaction. I mean, is there a segment of the physician population that chooses RVUs and money over patients?
Well, first of all, I'm more fascinated that you're a surfer than you live in Oklahoma. I had no idea.
Well, I didn't live there my whole life.
Okay.
Come on.
I did not.
Come on. Right. Pacifica called me for a long time, man. Come on, bro.
Where were you surfing in Long Island when you were in New York City?
No. So in New York City, I windsurfed. Huh. And I started windsurfing when I was a really small boy, probably 5 or 6. Everybody windsurfs and kite surfs in the Netherlands. And then when I got to San Francisco, you can do both. You can windsurf, you can kite surf. I did a lot of windsurfing in the Bay, and then the guys at Pacifica taught me how to surf, which was crazy because it was cold.
Yeah,
it was cold.
But
the old guys longboard, and I was like, I'm used to it. I'm a windsurfer, so I was like, I can longboard. So it took me about a week and a half. Yeah, and then I got to do it. It was, oh man, I loved it. God, I just get so mad when I think about Newsom. That he's such a nuisance. I love San Francisco, and I'm like, jag off. Okay.
Nah.
Anyways, so did And did I get the gist right? Did you guys see this on X? Because I know you're on X.
Yeah.
Probably as
So
much as I am.
I think I'll be the controversial one again here and say,
Yeah, please.
There's no question that doctors respond to incentives. And I think it's foolish to think that we don't. I don't think that is a main driver of healthcare costs, though. People doing a fusion when maybe a laminectomy could do. Sure, I think that does go on. There's some studies that have shown it. But I think it's relatively minor. I think most doctors, again, if you wanted to central plan it, it's not going to work because there's so much nuance that goes into decision making that it's really hard to say how much of that nuance is due to maybe a uncertain RVU incentive versus not. But the bigger drivers of all this are the health systems. Again, going back to it, you want to talk about something where choice of treatment really drives incentive behavior and rises costs. Look at 340B, right? You make a huge spread off of expensive drugs and you make a small spread off of cheap drugs. So there's clear data showing that once hospitals become 340B, once they acquire oncology clinics under their 340B umbrella, they start choosing more expensive drugs. The use of biosimilars goes down, and this is billions of dollars every year. So this is a lot more than the choices that physicians make using RVUs. This is billions of dollars being funneled to the health systems for the choices they make. The health system reimbursement for the different types of procedures and surgeries dwarfs what we get paid for those procedures, right? So a health system that does a lot of lumbar fusions, the physician fee is a drop in the bucket compared to what the health system's making. So it's really the health systems and the treatment. I think they're influencing a lot of these treatments going towards more expensive things and not as much the physicians. Does it go on? Yes. Physicians are prone to incentives too, but not to the extent that the health systems do it.
Dr. Choi, if you got in a room with Dr. Kennedy, what would you say to him after hearing this?
I'm a big believer in much of the Maha movement myself because of my personal experience with honestly I think I grew up with a sugar addiction, Lucky Charms and whatever Frosted Flakes, growing up with growing up in that generation. I never checked my added sugar. I never checked what was in my food. I was
the food pyramid.
I definitely have. I built up some insulin resistance. I thought it was healthy, but I really wasn't. Mid 30s, and it had a lot to do with our food supply. So I get where he is coming from, and I get where Casey Means is coming from. I've listened to a lot of their podcasts. I actually believe that our food is a lot of the problem, but and I wrote about this recently on X, is that I think it's super misguided to all of a sudden think that all the sick people in America who have sustained all this damage from our food supply have been sedentary their entire lives, are diabetic, are obese, have hypercholesterolemia, are suddenly just going to vanish with the Maha movement, or AI is going to just, ChatGPT is going to fix this for us or whatnot. It's not going to happen. You're going to get diabetic ulcers. You're going to get MIs, strokes. I mean, it's just starting. I think there's a tidal wave of our older generation who have sustained this and lived this sedentary life. I see it in my office all the time. I think I've talked about this, where patients who are obese and overweight are the ones who have the back problems, and they're the ones who need spinal surgery, unfortunately. And the demand for that end result, the end organ damage, right, for all this chronic disease, it's just starting, the tidal wave. And so for someone to be in that leadership position, and politics is politics. I think a lot of this is posturing, right? Physicians are an easy target always, right? You blame the physicians for COVID. You blame the physicians for the COVID vaccine. Then you blame the physicians for and look, you know why? Because a lot of the times they're going to know that the AMA is not going to respond forcefully. They're going to play this. Doctors do not, play offense well, right? We're always defense, and we always say, "Oh, we're here to take care of the patient," which we are, right? We have an oath. We're never going to abandon our patients, but they use that against us, and they pick us apart, and we are an easy line. And I don't know what's happening behind the scenes, or what his ultimate line of thought is. If he's solution oriented, he really wants to fix what the problem is. and the Trump administration actually wants to fix this. And I was thinking about this the other day, right? You think about the ACA 15 years ago was this huge step. We took a somewhat free market system, and we turned it socialist, right? We like took this one big step to and they got this done with a Democratic controlled House, Senate, and they were talking about healthcare reform. They took this big chunk and they moved it over into socialist market. Why, why isn't the Trump administration using this opportunity to move it back at least to that neutral mark? Because this is what's badly needed right now. I don't care what RFK says, out loud. If he's going to blame doctors, I think it's posturing. I don't trust any of these politicians at the end of the day. But I care about the actual solution, right? What is he really thinking about? I think he's saying all this so that ultimately he can go after the AMA for its stance on vaccines and all the other things that they've taken stances on against the Trump administration. I think it's all political posturing for that personally. I want to look at what are they doing from a free market standpoint to go after health insurers, to go after corporate medicine, to make sure that we increase clinical throughput for the specialists. You cannot handcuff the specialists in this country even more and provide less care. You are going to drown in the tidal wave. That is what's going to happen if that's his actual solution. If he thinks we're going to defund the specialists and then take those dollars and fund some nutrition movement in America, good luck, my friend. And you know what? Maybe the media won't cover it, but patients, we know the patients are going to be suffering. Our aging parents, our aging grandparents who are going to be having the strokes and the heart attacks and back problems and everything else, the joint problems that come with the obesity pandemic in this country, we know they're going to be suffering. And whether this administration cares about that or not, honestly, I don't know now at this point. And I don't even think they have any kind of impetus or motivation. I haven't sensed any that they want to move back. I mean, I know Trump took on the ACA, his first administration, and he just didn't have the things, the political, everything lined up. I think he might have given up. I hope not. And I really hope that they do something about healthcare, this administration. It is something, it's not an 80-20 issue. It's a 95-5 issue. 95% of Americans think healthcare is not working for them in America today. He needs to fix it. That's what he needs to do.
Dr. Koka, we were talking about Kennedy blaming doctors for choosing not to heal people when they can give them cures and help them out. And instead, he says that they choose higher price treatments and money instead of healing. And so that's the question. Is that something that really you expect to hear? Do you think it's political posturing? Give me your take on that.
I think the way I view it is, I agree with Dan that this idea that America is mostly sick because of the health system is probably untrue. It's that famous life expectancy versus per capita GDP chart, which is kind of completely bogus and just, is not an indictment of the health system. Yes, things are too expensive for everything all the reasons that we talk about. Yes, we have outcomes that are not necessarily great in certain areas, but a lot of this is driven by choices that that Americans are making, and then they end up on Dan Choi's door or Anthony's door. After decades of poor choices. And so in some sense, what Kennedy's talking about is a reset of those choices. And I think, of course, because he's not on the inside in terms of in the physician community. I think he's coming at from the outside perspective that he's just been burned by all these decisions that physicians have made, which he deems as incorrect. Whether it be the food pyramid, whether it be pushing vaccines that he believes don't work and are certainly some vaccines he believes have harmed people. So yeah, I think he's trying to point the finger at everyone but folks. At the same time, I like the fact that I like what he's talking about in terms of SNAP, right? So, yeah, I mean, I think I would take it as a little bit of a rambling answer, but I think I would take it as there are some elements of truth to what he's saying in terms of, yes, there are aspects of things that public health has got wrong. Famously, don't eat cereal every morning. Don't eat your Fruit Loops every morning. Don't eat Honey Nut Cheerios every morning. I mean, my God, that's like, 30 years worth of, people pushing that and the AHA endorsing it and whatnot, So there's certainly, doctors have a role to play and a part to play in that. But yeah, Dan's right. I mean, obviously if you go overboard, that's not going to look pretty, from a physician standpoint. I do like the fact though that I think we focus a lot on that because we're doctors, of course, but I don't think he just has his target, has a target on the back of doctors. I think he has his target on the back of a system that is kind of making America and making Americans unhealthy. And there are elements of truth to that. So
I think it's hard. And I do think what Dr. Choi said is right. I think physicians are an easy target. Right. And I wish that he would come and spend some time with us and learn about the independent practice of medicine. And he would talk to the physicians that are employed that know better, like Dr. DiGiorgio. I don't see that happening anytime soon, but Dr. Choi brought up a really good point. Well, he brought up several good points. I'd love to hear from you, Dr. DiGiorgio, about one of the things that Dan just said was what he would like to see the administration do. What are 2 or 3 things, if you kind of had your wish list, Dr. DiGiorgio, what do you want to see? You guys are knee deep in advocacy. What do you want to see them do in the next year? I keep seeing these Trump 200 days of winning, and maybe I'm just not political enough and I don't see all the wins. Maybe I just don't know. I'm not cool enough. Although I am in Washington, D.C. a lot, and I think he's winning, but I'm like, I don't know. So like, I'm a healthcare guy. I want to have wins in healthcare. I don't really care about anything else. And that's a bias on my part. But if you could have 2 things, 3, 4, maybe, like, what do you want to see that you think will have great impact? Doesn't have to have the greatest impact, but a great impact on patients.
Yeah, I think whatever they could do to help physicians regain independence. So you could do, legislatively to overturn the ban of POHs. But if we're talking about what he could do administratively, you could do a CMMI, a demonstration project for physician-owned hospitals, say in rural areas, underserved areas, et cetera. Number 2, site neutrality. And I would couple that with 340B reform. So you really take the thumb off the scale of the large hospital systems, reverse the consolidation effects.
I like that answer about site neutrality. So I talked to a couple of lawmakers, policy wonks, and I said, what would it really take? And I posted it on X the other day. I got some pushback on it, but it was literally like, it's an administrative move. Like, it requires a pen and paper, like, this is what we're going to do, CMS. We have to do a study on it, but it can be retrospective. Like, we can change the rule and then we can study it and come back. But I don't understand why we don't do site neutral payments. And when I talk about site neutral payments, I'm not talking about reducing all the expenses down to what the ASC level is.
Yeah, come to the medium.
Yeah, come to and then my other question, I guess, for you, Dr. DiGiorgio, is when you and I talk about this on X specifically, because I see yours, physicians immediately assume that everything's going to come down to the bottom. Why do they do that? Because I think it's going to go up. I'm like, no, we're going to move up.
Look what they've done with our conversion factor, though. I mean, it only goes one direction. But yeah, I'm hopeful that they would come to a middle, because the whole reason that you have this lack of neutrality is because there's 3 different fee schedules. You have an inpatient fee schedule, an HOPD fee schedule, and an ASC fee schedule, and then you have the physician fee schedule. So you really have 4 fee schedules. And so all they need to do is basically equalize those. Unfortunately, what they just did was they took down the practice expense reimbursement for anything a physician does in a hospital, which kind of go in the wrong direction. I wish they hadn't have done that, but I think if they paired that with some sort of site neutrality, I think that'd be great. But if you don't tackle 340B at the same time, you've not undone the big, huge thumb on the scale in favor of the large hospital systems. They're simply going to shift resources over to more 340B maximization. And unfortunately, true 340B reform, the administration can do some things through HHS and executive order, but true 340B reform is going to require legislation. And I hope there's the political will to tackle that. But that's a much bigger, fish to catch? I don't know. I don't have a metaphor.
Mm-hmm. Dr. Koka, I'm really interested in your answer on this because you're so anti-government. You make me look so like I think I'm anti everything. And you're like, no, just let the free market handle it. If there were 2 or 3 things, you're having a cup of coffee with Secretary Kennedy, and he says, Dr. Koka, you're this world famous cardiologist. Dutch Rojas is your biggest fan. He's such a great guy. And he says, what can I do to really set the free market free when it comes to healthcare? What are you going to tell him? By the way, I think you're going to have that conversation soon, so I'm preparing you guys.
I like deregulating to allow lower cost places to kind of sprout up, and I think that would really be very huge and may get around some of the political problems. Well, it's still going to be a political uphill battle, but maybe it's a little easier to do. So maybe that's practically the easiest thing you can do, is to really open the really push hard using your federal hammer to allow a bunch of places to kind of come up that would compete with hospitals and would do the same procedure at a much lower cost. And that would be so huge. I mean, right now to open up an ASC in Philadelphia, say a cardiology ASC in Philadelphia with like 2 rooms, right? Yeah, it's like a 2-year endeavor. There's like DOH is on your back. There's like all kinds of regulations. I mean, it's insane. And then, I mean, the amount of regulatory hurdles that exist to just, opening up, a shop to compete with hospitals is insane. I mean, hospitals are impossible systems. I mean, it's insane. It takes it took me like 10 hours of emails just to talk about why verbal orders are actually permitted.
Get me started.
and there's like
CPOE.
Oh my God. And there's like 55 million people that are like, no, I don't think so. I mean, CMS may cite us. CMS, we have to be careful about JCO. And there's all these acronyms that people are throwing left and right. And I'm like, I mean, even the AMA, which is no great, whatever, even the AMA says that verbal orders, that you can't give verbal orders is a myth. I mean, so it's just, we really have to, and so I think that would be the easiest thing to do, would be to create a separate system which is much less regulated. You know how you got like a vaccine in a year, Operation Warp Speed. Like we need like an Operation Warp Speed for like allowing like
MMI demonstration. I love that.
Yeah, exactly.
Well, I mean, we could have a federal rule that said no more certificate of need laws. Like they could do that in Washington.
Yeah, and
it's only because they accept Medicare payments.
And you set up like a team of 3 people, right? And the 3 people would be Dan Choi, Dutch Rojas, Anthony DiGiorgio, and they would be the ones deciding. They would be the regulators that would decide whether not like Pennsylvania DOH, New Jersey DOH, ACGME. I don't know ACGME, whatever. CMS, this person, that person, nothing. You answer directly to the 3 of you. The 3 of you answer directly to Bobby Kennedy, and that would be insane. I would
do that job for like $1 a year. I just volunteer for a while.
I would do it, but only if I answer to Anish Koka.
Yeah, the crazy, for our listeners who might not be familiar with like a verbal order, what that is basically if you're in the hospital, let's say I'm getting ready to do your surgery, and I get this all the time. Preoperatively, I have to order Ancef, right? It's a antibiotic before surgery. We always give Ancef before every surgery, unless the patient has like a penicillin allergy, then you go to vancomycin or whatnot, or clindamycin. So it's always given. Sometimes the preoperative team has not ordered it, the anesthesiologist has not ordered it, so they come to me, be like, "Hey, Dr. Choi, can I take a verbal for this antibiotic?" I say, "Yes, the antibiotic, yeah, go for it." So that's what a verbal order is, right? So whatever hospital you're working at, Anish, has now challenged our ability to say yes. How long for?
You can only do it in a life-threatening circumstance.
Crazy, because there are so many, 99% of the circumstances that we operate under
are non-threatening? And do you want your physician, when you are there
By the
with
way,
your family trying to treat a heart attack, being stopped, saying, the nurse looking at them goes, sorry, doctor, the hospital administration has decreed that you need to stop your care, stop your chain of thinking and your line of thought, and you need to sit down on Epic and spend 30 seconds logging in, opening the chart, getting to orders. Actually, it's more than 30 seconds, and a minute and 30 seconds.
Oh,
At least
we've timed it with our residents.
No way. How long does it take?
It can take, so to put in an MRI takes about 90 seconds and it's about 57 clicks.
57 clicks.
Clicks and keystrokes. Yeah.
And that's
Yeah.
that's 90 seconds of you losing clinical momentum. Like if I'm racing and I'm focused on, I'm thinking about your surgery. I'm like thinking about, okay, I need to go on the right side and make sure we decompress that foramen. And I'm assessing the patient, and all I'm thinking about is like, I'm going to make this surgery. I'm going to make it go smoothly. I'm going to make it go perfectly. And all of a sudden a nurse goes, doctor, stop what you're doing. You need to sit down and put in this ANSEF order. I would not work at the hospital. That would be a pick for me as a high performing surgeon who does perfect surgeries. I tell my patients I'm perfect. I work and I am very intense on the morning of my surgeries. I'm in the zone. Don't talk to me.
I believe
Ask me about,
I feel it.
don't ask me about my weekend. I'm sitting there getting ready for the surgery, thinking about if you interrupt my chain of thought for an Epic order, I will not work at your hospital. I will not work at that hospital because it is a patient safety issue. People think, oh, doctors, they have this God complex. Oh, you can't even sit down and write a ANSEF order. It's not a God complex, okay? It is me knowing and you know what? What's crazy? You guys should watch this HBO series. You know, we're stuck at home, so I'm watching a lot of HBO. I'm watching The Nick. Have you guys heard of The Nick?
Yeah.
No.
Yeah. A lot of cocaine.
It's medicine practiced in the 1900s in New York City. You know what? When you watch that show, you actually get turned back into a time when the physician was the leader. Okay, the physician, everyone looked to the physician and said, doctor, what do you need? What do you want? It's not a God complex. It's because back then, there was no technology. There was nothing. I mean, they were doing all crazy things, right? And patients died. They went into the hospital, and if you needed some type of surgery, you were dead. Like you were, and still in that time period, the doctors were trying to do the best they could for the patients, which still happen. That's our oath. We are trying to do the best thing for the patients, and we are focused on patient care and making sure. For me, again, that morning, I want to make sure that surgery goes perfectly. You should not interrupt a physician in their clinical decision making and in the zone trying to make things perfect for the patient to excel and do what they were trained to do. And these are these little microaggressions and the micro things that get in the way that lead to early burnout, lead to physicians going, you know what, it's just not worth it anymore. And so I'm telling you that this is a great example of something that people will say, oh, physicians, they're just so dramatic. It's not. We want to take care of you. We want to take care of the patients. Let us do it. And you need to give us control and leadership.
It's a great example of.
Okay, give us your give us your thoughts. I want to hear from you.
Yeah, it's a great example of computerized order entry. I mean, in terms of computers, EMR, Epic, it's going to make things so great. I mean, it's going to be like everything's going to be quick and boom, internet fast, blah blah blah. And like literally, it is tied us up. It has tied physicians up so much, and has given power to so many non-physicians to be like, wait, you got to put it in order. If you don't put it in order, then it's a safety issue. It's a patient safety issue. I'm sorry. Like, it's like, actually, it's not. It's actually, it's getting in the way of clinical care. So So, in terms of what we need to do, we need like an operational, we need, just like we had a mission to moon where it was like, that people aren't answering directly, not going through the regular channels or whatnot, right? For some period of time, you're just like cutting through all the regulatory BS. That's what you need. And I think that would, that more so than anything would be huge, in terms of, and that would solve the problem of like, one of the huge problems in healthcare that we have to speak to as physicians is the cost of healthcare. The cost of healthcare is massive, right? We have to be leaders in terms of championing, decreasing the cost of care by allowing for a lot of these super high cost procedures that are currently being done in hospital settings, to be done in non-hospital settings. I think that'd be big.
Dr. DiGiorgio, last comment.
I mean, tying it all back together, institutions that have done strictly away with order entry have placed that burden largely on residents. And it's tragic to see what residency training has become. Residency training is not about learning to be a physician or a surgeon. It's about learning how to be as efficient as you can in the EHR, because if you're not, you will never leave the computer. We published these results. We pulled the Epic audit logs from our residents in a 24-hour in-house on-call shift. They spent 20 hours on the computer, and of that, 21% time was done within order entry. Our residents get paged on average for a 24-hour shift once every 90 seconds, largely for order entry. And it's not just like, can you put the ANSEF order in? It's like, the patient has all their medications ordered PO, but they have an NG tube. So you have to go in and you have to change every medication from per PO to per NG. It's things like this. And that's just, it's absolutely maddening that you're requiring a licensed physician to go in and do that, when their efforts could be, as Dan said, much better aligned with what the patient wants their physician to be doing.
And the person who's making that decision is not a physician, I guarantee you. With telling whoever's regulating that and saying it needs to be put in by a physician, it's a non-physician who doesn't want to necessarily burden the nursing staff and says, you know what, the residents can do it.
That's exactly what happens all the time.
Never make that decision.
Right. And it's embarrassing that so many physicians are actually silent about that. There's a bunch of physicians that are silent about that, don't stand up for it, and just like, oh yeah, the residents can do it. Oh yeah, the residents can do it. And I think it's embarrassing, and we should stand up more.
Okay, great conversation. I'm really thankful for Greg Murphy's posts, and I'm thankful that Secretary Kennedy decided to tell us what he thought about physicians. But I'm more thankful for the three of you. I missed Dr. Dixit tonight. He was on break. And next week, I think we're going to talk health system prices, cost of healthcare versus insurance premiums, and the broader economic fallout, amongst other things. I'm looking forward to seeing you guys all next week. And congratulations, Dr. Choi. I am ecstatic for you and your beautiful family to have another one. Man, this is just the greatest thing of all time. Greatest thing. Congratulations.
Thank you. Thank you, guys.
Congrats, Dan.
Thank you, guys.